So hello, everyone. Welcome to day 2 of the HiTOP workshop of integrating HiTOP into clinical practice. And this morning we have presentations from Chris Hopwood and Stephanie Mullins-Sweet. And so I'll go ahead and turn it over to, I'm not sure if you guys have talked about who will go first.
Well, Stephanie was listed first in the program, so people will be disappointed to know that I'm actually going first instead. So I gather that our goal is to talk about HiTOP in clinical practice or something along those lines. And I'm Chris, and Stephanie's also probably on your screen. So we divided it like this, that Stephanie wrote a paper a few years ago about how different spectra or diagnostic dimensions within HiTOP could map onto different evidence-based treatment techniques. And I gather she's going to talk about that bit, which leaves the scree for me, I suppose. And so I'm going to talk about other things that might be interesting. And to do that, I want to put in our heads a case that's similar to a case I once saw, who we'll call Dexter. Dexter is a 25-year-old young man who presented following his first ever suicidal gesture. Not a super serious, potentially lethal, but not considered a serious suicidal gesture. He did relatively well in school, had a bachelor's degree, but was currently unemployed, came from a conservative background culturally that didn't fit his values all that well, and as a consequence of that and other things, is out of contact with his family. Currently has no romantic relationships and a pretty thin social support network. Not a lot of evidence of psychiatric issues in Dexter's past. No known substance abuse, trauma, treatment, or legal history, but is preoccupied with questions about gender identity, sexuality, said something along the lines of, I feel all alone and that no one understands me. And that was the his internal context of the suicidal gesture. So this is what you might know if you're working at a clinic from an intake. You might get a note that has this information on it, and maybe there will have been some kind of screening procedure using HiTOP instruments that gives you scores on the spectra and the general factor. So the first. So I like to think about this like, what would we want to know about a person and in what order, as we're thinking about how to approach helping someone like Dexter. The first set of questions are quite general, at least in my head, normally speaking. They have to do with the overall level of a person's problems. So what level of care might this person require? Do they need to be in an inpatient unit? Do they need constant supervision? That would be the sort of highest level of care. Do they need treatment at all? No treatment would be the lowest level care. And of course, there's a range of possibilities depending on the healthcare system that you're working in between. A lot of times we think about like one session a week as a sort of standard level, but there's a variety of different levels around that. And of course, the more severe the patient's problems, the more likely that level of care will need to be intense rather than otherwise. A second question related to general severity of problems has to do with prognosis. How do we expect Dexter to be doing? Now, of course, there's other factors in prognosis. What does the specific diagnosis end up being? What's the course of that diagnosis, et cetera? What are the treatment prospects? But the strongest empirical predictor of future prognosis is overall severity of problems. And so the general level of Dexter's problems can help us make guesses about how well Dexter will be doing in the future. Third, overall, what's the level of risk of this kind of case? By risk, I mean things like another suicidal gesture, this time maybe more serious, a suicide attempt, trying to hurt somebody else, disengaging with treatment services, doing something that will present Dexter with more challenges in his life moving forward. Again, the more general psychopathology a person has, the greater the risks there are for all kinds of things like what I just talked about. And finally, when you're thinking about doing psychotherapy with a person like Dexter, you want to think about how easy is it going to be to engage them in treatment? Is it going to be easy to develop an alliance, to get them to cooperate, to get them to buy into the ideas that you're selling, to get them to engage in treatment? Or are there going to be challenges? And again, the strongest individual level predictor of therapeutic alliance is the patient's overall level of psychopathology. So these are fictional scores for Dexter on the high top measure. And you can see the scores here. I imagine these as T-scores against a normative population. So the Dexter has a score in general psychopathology of 75. And on the spectra, the highest scores are internalizing at 88, detachment at 85, thought disorder at 78. Most of the other scores are within normal limits. Antagonism is up here around 62. So that gives you a little bit of sense of what he's like. And of course, those things combine into a high to moderately high general factor. So we would say that his overall level of psychopathology is high to moderately high, is indicated by a couple of different ways of thinking about it. One, his P factor is 75T. But also he's got problems in multiple different areas, as indicated by 3 high scores across the spectra. He's got pretty high acute distress. And from what we know of Dexter's history, he's got a downward trajectory, meaning that his psychiatric problems seem relatively recent. It's not clear what that means. But right now we know that his life is probably about as bad as it's ever been. So that might suggest to us, again, without knowing anything else about him, that immediate support and evaluation are in order, that we should be a little bit cautious about prognosis. We should be worried. You might already have some potential kinds of psychopathology in mind in terms that could help inform prognosis further. The risk is, we should probably assume the risk is kind of high at the moment, given that he's coming in with a suicide gesture and that his distress seems quite high and that he doesn't have much in the way of social support. And his alliance prospects are concerning. He's never been engaged with treatment before. He doesn't seem to be doing all that well with coping. He hasn't been able to make use of any potential social support. It's not clear how he'll be able to make the use of the kind of support that clinical services could provide. On the other hand, it's possible that psychotherapy provides exactly the kind of support that Dexter is missing in his life. So we have the sense that this isn't the most severe case maybe we'll ever see, but it's pretty concerning, and we want to probably act carefully and act quickly with a person like Dexter. So that's one thing that the general factor can give you. That one piece of information, how severe is a psychotherapy intake, can give you a lot of information about things like level of risk, level of care, prognosis, prospects for alliance, without knowing anything else that's specific about the case. And indeed, in the empirical literature, this generally tends to be the variable that predicts things the best. And there's not a whole lot that other specific variables can do beyond sort of adding up all the symptoms that a person has to try to predict their future prognosis, their level of functioning, their engagement in treatment, et cetera. Okay. I want to talk about a couple of other things that the general factor can do as well. One of them has to do with outcome assessment. Now, of course, if you're treating an individual patient like Dexter, what we're going to want to do is go to the level of like, what is his specific diagnosis? And even better, what are his specific problems? And then we want to see whether our treatment's working by assessing change in those specific diagnostic or problem variables. But if you're trying to measure whether a clinic is working, whether treatments are working across many patients, the one thing that all patients have in common is this general factor. And so this becomes a reasonable proxy for mental health in a group and can be used as an outcome variable, just as it can be used as a predictor variable in clinical research. This is a little bit speculative, and it's not evidence-based, but one way to organize treatments is also in a dimensional hierarchy. And indeed, there's a lot of literature, of course, about the difference between common and specific factors, and the specific factors can often be conflated with therapeutic orientation. But the fact is that there's a lot of different ways to go about treating people, but we also know that there's a lot of things that, generally speaking, clinicians should be doing regardless of the kind of patient that they're treating, things like empathy and building alliance and developing positive expectancies, et cetera. And so these common factors map on in a way that's kind of parallel to the P factor or the general factor of psychopathology. And in fact, this is one way to think about how treatment interfaces with psychopathology and diagnosis, is that there's sort of stuff at the top that's very general. Oftentimes, in a predictive sense, it carries the most weight. So common factors tends to be a better predictor of treatment outcome than specific factors, just like general psychopathology tends to be a better predictor of outcomes than specific factors. But then, of course, in order to understand an individual person and develop a specific treatment plan, you have to go beyond these factors and think about how specific interventions will map on to that person's problems. So let's go one level down the hierarchy and talk about the possibilities for Dexter's diagnosis. I've highlighted here in red the spectra where Dexter is most elevated. Within internalizing distress was his highest score, and in particular, depressed mood seemed to be a prominent feature. Within thought disorder, he had significantly disorganized thinking. It wasn't clear based on what we know so far whether this was acute and related secondary to distress, or whether this was something that was coming along and was causing distress. And so that's something, of course, that you'd want to use a more specific evaluation to figure out, because the differential there is obviously important. His presenting complaint has to do with social support and identity problems. In particular, not knowing who he is and not feeling like he understands himself, but also not feeling like anybody else is there for him or is able to understand who he is. And he has some anger that he doesn't know what to do with that, and that's where the scores on antisocial, on the antagonistic spectrum and antisocial behavior in particular came up. So what's interesting is that he's not impulsive. He's got low scores in impulsivity. So he's got a kind of seething anger. He's really resentful and contemptuous, but he doesn't quite know what to do with that anger. So this starts to give us some ideas about what kind of diagnosis he might have. You might think, well, this is a person who is going through a lot of stuff and therefore is pretty distressed about it, and maybe depression would be a reasonable way to think about this person. You might think this is a person who hasn't sufficiently developed an identity, and maybe something in the area of personality disorder would be the best way to think about him. You might think this is a person who at this age and given the trajectory and given the symptom pattern is at risk for a psychotic disorder. And that might explain his symptoms. And again, I'm not going to talk about that in too much detail, but the differential there is obvious. And you might think, well, why is the differential obvious? Because that would inform treatment. But if you want to know how diagnosis maps onto treatment, you have to ask Stephanie. We agreed that's something she was going to cover because it's too hard for me. I did want to talk about one other issue, and that has to do with pathoplasticity. So HiTOP, relative to categorical diagnosis, HiTOP as a dimensional hierarchical system can do two things better than categorical diagnosis in a way that's quite clear. One, it solves the problem of comorbidity. So given that different disorders can fall within the same specter or load on the same factor, shouldn't be surprising that people have two diagnoses at once. We hear about that all the time within HiTOP. The other thing it can deal with is heterogeneity. And this has something to do with a much deeper feature of the HiTOP model, which I find particularly attractive. And that is, it's a model of individual differences. That is, it's a model of personality. That is, it's a model of the whole person. And so philosophically, rather than trying to screen out information to find what's most important so that you can hone in on the specific diagnosis that will lead you to a treatment, the approach is to be able to both go in and out from specifics to general. And the advantage of being able to keep the general in your mind, that is to keep this whole figure that we're looking at, the sort of canonical HiTOP figure, the advantage of keeping that figure in mind, even as you're able to zoom into the specific, is that you can keep that whole person in your head, right? And the reason that that's important with respect to heterogeneity is a lot of times two patients with the same diagnosis can be very different personologically because of patterns within this figure that aren't directly pertinent to diagnosis, right? So two depressed patients can both meet, say, 9 out of 9 DSM 3, 4, and 5 symptom criteria for depression, but one might be impulsive and angry and get in fights, and one might be broody and detached and never go out, therefore never fight with people, right? And as a clinician, I want to know what the central symptoms are, but I also want to know what kind of person I'm dealing with. And HiTOP not only because of its concrete practical format, but because of its philosophy and its roots in personality psychology, allows you to keep the whole person in mind. And so you can not only ask, what is this person's problems, but what kind of person is it that we're talking about in a way that may be unrelated to their problems. So I sort of, this is like one of those books from my childhood, the choose your own adventure book. So let's say that you turn to page 11 and we decide, okay, depression is the best diagnosis. That then becomes the treatment target. Then whatever Stephanie tells you about how to map treatments onto disorders, that's what you would do. And you would measure depression as the core outcome variable to tell whether your treatment's working. But you'd also want to know something about how to engage with Dexter in trying to help him overcome depression. And knowing that he's angry, but has a difficult time expressing it, knowing that he has disorganized thinking, and that's a prominent feature of his personality, knowing that he has these deep questions about who he is and how he fits into the world, but also knowing some of his strengths, like he has good health, he has education. These kinds of factors can help us get a sense of who he is as a person and help us engage with Dexter, independent of how we think about whatever the specific treatment for his core symptoms are. So you turn to a different page and decide, no, this is an emerging psychosis. That, of course, has very different treatment implications, depression versus psychosis. But again, two people with the same schizophrenia diagnosis can be quite different from one another. In this case, it would be interesting. It's important to us to know, again, that the context of his psychosis is a kind of distressed, internalizing presentation involving suppressed anger and identity problems and kind of over-controlled impulse, over-controlled presentation. So he's kind of bound up and distressed and seething on the inside. And there may be a lot going on inside if it is a thought disorder that wouldn't be expressed so readily on the outside, and that would distinguish him from other patients with the same kind of diagnosis. And again, there are strengths, and that's one of the things that thinking about people from a whole person perspective can tell us, is not only what are his problems, but what kinds of things are not problems for him. And health, I just list here as one example. Finally, if we decide, we turn to a different page of our book and we decide, okay, Dexter has a personality disorder. I don't know if we're still allowed to like say which one or whatever. I'm not really super interested in which disorder. I think that's not super interesting to me, but rather the general idea of personality disorder or personality dysfunction. That is difficulties interacting with others and difficulties understanding oneself, identity problems. If we say, well, that's really the core of psychopathology, then again, we sort of get a flavor from the rest of the high top, not only of what his problems are, but what his potential strengths are. So I probably made this point by now, but I guess the summary is that when you're treating somebody, one thing you want to know, and arguably the most important thing you want to know, is what are you treating specifically? But the second thing that you want to know is what kind of person they are and how do you engage with them, and keeping a sense of the whole person through a model that's comprehensive along the lines of high top, and which allows you to zoom in and zoom out, enables us to do that. So there's from a high top perspective, as it interfaces with psychotherapy, there's a kind of 4-step process, right? The first step is how severe is this person's psychopathology overall? And that has implications for, again, prognosis, level of risk, likelihood of alliance. The second question is, what general areas are the problems in? And that starts giving us, so at the level of spectra, that starts giving us a sense of, well, what kinds of measures, what kinds of symptoms, what kind of measures should we give to follow up symptoms more specifically to get a better grip on what the most likely diagnosis and therefore what the most likely treatment targets and therefore like the most likely treatment approaches would be. The third level is, what are those specific symptom components or traits, and that will then tell us what diagnosis we should put in their chart, the value of that diagnosis varying maybe across patients and across providers. But ultimately, when I'm treating a patient, I usually want to go beyond that level to the most specific and lowest level of the high top hierarchy, which is, what are the specific problems that this person is struggling with? Those are the things that I ultimately would want to measure as change, and those are the things that I'm going to target in treatment. So what do you do with those things? Will you make a formulation? How do you do that? You have to ask Stephanie. And I think I'm a little bit short, but that's okay because other people probably have more interesting things to say than I do, beginning with Dr. Sweet.
Hello. Good morning, good afternoon, good evening, wherever you are. Happy Saturday. It is morning here. And I am going to take a step back from where Chris left us. We're gonna dive into treatment. I'm gonna sort of take a step back first and talk some broadly about evidence-based practice and how evidence-based practice can be useful to us when we think about clinical treatment using the HiTOP model. So as I'm sure that many of you are familiar with, that there has been a push for evidence-based practice, both in psychology, psychiatry, and medicine in general that dates back to the 1890s. In 2006, more recently, the American Psychological Association published a book, Evidence-Based Practice in Psychology. That really led to a wealth of research and dissemination on various evidence-based techniques and empirically supported treatments that has now become a focus in many areas. So it's really important that I first have a disclaimer that today we're primarily going to be talking about adult treatment and adult therapy. In fact, I think that's entirely what I'll be discussing. Yesterday, we briefly talked about how the HiTOP assessment and HiTOP measure right now is focusing primarily on adults. So that's really what I'm going to talk about today as well. But evidence-based practice has been brought into child therapy, evidence-based assessment, as well as making cultural adaptations for minoritized, marginalized, and historically excluded individuals. So this has been a real focus area. Now, I do want to make a disclaimer. Of course, not everyone is fully on board and embracing evidence-based practice as it's defined by APA, specifically Division 12, with one criticism being that cognitive behavior therapy is really overrepresented in the number of empirically supported treatments and evidence-based therapy. So it's really important that I provide my perspective and acknowledge that my training has primarily been in cognitive behavior therapy. So that is going to influence the things that we talk about today. I have tremendous respect for other evidence-based treatments and other treatment modalities and perspectives, but that does sort of flavor my knowledge base. I've tried to be inclusive when feasible. So as you'll see, there are lots of disclaimers throughout this presentation today, in part because we know that the HiTOP model is young. And so making these sort of applications are sometimes going to be speculative. And I'm going to talk a little bit more about that throughout the talk today. But we do know that much of evidence-based practice has been based on DSM disorders, and the research that we already have that sort of led to the development of the HiTOP model can be applied here to think about how can we use the HiTOP clinically. In fact, a lot of past research on psychological treatments focused on specific disorders suggests that treatment has sort of broad implications. In fact, suggesting maybe our treatments can be more specific at transdiagnostic factors, and the HiTOP spectrum may be these transdiagnostic factors, which would suggest that this is a great place to look when we're trying to find treatment targets. So Camila referenced yesterday that we can use HiTOP spectra in a variety of ways. We can use the HiTOP spectra in developing our overall formulation of clients and developing treatment plans for symptoms. We can use the HiTOP spectra focusing on these specific treatments and how these treatments apply directly to elevated components and traits. And we can also use tailoring and matching. So I think that Chris's example of Dexter is a good one of how certain traits might not be elevated, but may have big impacts on treatment. So we need to look specifically at that whole person and match our treatments to the whole person who's in the room. And really, this is consistent with our field's push to treat these transdiagnostic constructs. So I mentioned some disclaimers. Another disclaimer today is if you were here yesterday, I know that there were a few questions about the structure of HiTOP and specifically how we measure it. And HiTOP measure right now really is from a unipolar structure, with most of the most useful information being at the high end and it not being quite as precise at the low end. So in the interest of time, my recommendations today are going to focus on that high end. You'll see that I do include within my discussion some of potential recommendations for the low end as well, but we're just not going to have as much time to get into that today. So before I get into the recommendations, just a reminder, a caveat here that a lot of this is either evidence-based speculation, or is taking constructs like the alternative model for personality disorder or general personality or DSM disorders, these HiTOP adjacent constructs, and looking at the recommendations that we have for those and mapping those into HiTOP. As we're going to talk about, more research needs to be done to explicitly connect HiTOP spectra to treatment recommendations and outcomes. But we'll first start by talking about detachment. So detachment, in some models, it's also called introversion. So some of our recommendations, we might think about what recommendations do we have for individuals who have problematic and maladaptive levels of introversion. And really this construct, as most of you are familiar, is the domain that focuses on interpersonal relationships, social communication, and these can be seen both within and outside the therapy room. And so that construct in itself is going to be really relevant to treatment because it's going to potentially impact the treatment relationship. So individuals who are high in detachment often lack interest in activities. They also may have difficulties with emotional expression. And so both of these are going to give us some clues as to what kinds of challenges we might find when we have an individual in the therapy room with us. So these treatment challenges might include, like in the case of Dexter, difficulties forming a treatment alliance. So there may be trouble here with those interpersonal connections. So when we have an individual who on the HiTOP DAT or a HiTOP adjacent measure, the HiTOP self-report, when that gets out, what do we do when we see a person sitting across from us who is elevated on the spectrum of detachment? Well, we have some hypothesized techniques that might be helpful. So some of these, again, are going to be more speculative than others. I will be sending my slides, and we can also link in the chat the article that Chris referenced earlier, where you can find all of the specific techniques and references for those. We'll get those to you so that you can see sort of where these recommendations are coming from. But when we have an individual who is sitting across from us and they are elevated on detachment, we're going to be thinking interpersonally. We're going to be thinking, does this individual need interpersonal effectiveness? Do they need to increase their assertiveness? Do they need training in social skills? Do they need some behavioral exposures? Are these things going to be helpful? If you have an individual who is coming in and they're experiencing marital difficulties, or if you're seeing a couple, I think it's really useful, particularly in couples and family therapy, to do some assessment as well, because you may find that there's a mismatch. You may have an individual who is really high in detachment and another individual who has really adaptive, less maladaptive, or maybe we might even say more extroverted tendencies. And there may be a mismatch within that relationship that is due to just difficulties in understanding how these two individuals are relating with the world. And so this information can be helpful for us to provide some psychoeducation to one another about how they're communicating, but it can also just be useful to say, you know, sort of like, hey, let's step outside of ourselves, and we can do that with some skills. So these are some things that we might be thinking about if we have an individual in the therapy room with us with elevated detachment. So we also can look at the spectra antagonistic externalizing. We know a lot about this domain. It may include some relationship dissatisfaction. Often there's conflict, some antisocial behaviors, more aggressive behaviors. We may see entitlement, callousness, manipulativeness. Antagonistic externalizing is often related with the initiation, development, and maintenance of substance misuse and problems related to substances. These individuals who are elevated and antagonistic externalizing may present with different treatment challenges than we would see in an individual with detachment. So we will often see these individuals may be distrustful. They may not be very excited or engaged with treatment. In fact, they may be presenting to treatment due to a court order. They may be presenting to treatment due to their employer requiring it, or their significant other requiring it. And so these are individuals who often may be hesitant or reluctant to pursue services. And therefore, that's going to have some impact on treatment alliance as well. However, we know that all is not lost. So this is not to say like, oh no, if you have someone who's elevated in antagonistic traits, that there is no there's no help and there's not going to be a treatment alliance. I think that's a real mistake and a misnomer that is sort of clinical lore that doesn't in fact hold up in terms of research or in the therapy room. In fact, there is some research that suggests that cognitive restructuring or the use of medication can have impact not only at the higher antagonism level, but also at some of the lower order traits like distrustfulness. So there's reason to think that we can build therapeutic alliance using the motivational interviewing techniques, things like ruling with resistance, building empathy. Those may have some promise for building that therapy alliance and then moving into some of the more cognitive work in an individual who presents with this elevated spectrum. Relatedly, we can also talk about disinhibition. I think this is probably most commonly when I work with students, that what we run into are some difficulties and therapy interfering behaviors that might be related to disinhibited or disinhibition externalizing. And so we know that this spectra relates to difficulties regulating or controlling one's behavior. This may land an individual in therapy because they're having work problems, career problems. They may be engaging in misusing substances. These clients may have financial concerns, health concerns, legal concerns, impulse control problems. So we see a lot of this within the therapy room. And then the real difficulty here is that these traits can lead to some behaviors that are disruptive in treatment. So often we will have clinicians who say, you know, I'm really struggling here because my client isn't doing their homework, or I'm really struggling here because my client is non-adherent to their medication schedule. So they're not taking their medication, which seems to be really helpful for them. They're not taking it on a regular basis, or they're not engaging in the activities that we've sort of given them to do on a weekly basis. And so that can present some challenges and can be disruptive to therapy. And so in reality, I find it extremely helpful to know, is an individual high in disinhibition, because that can help us in thinking not about like what specific treatment techniques are we going to use, but do we need to do some scaffolding? For example, is it helpful to set reminders on a client's phone? Is it helpful to do a midweek check-in? Like, hey, how are things going? Did you take your homework out of the car? Can you put that on your fridge? Can you put it on your nightstand? So just overall, that can be helpful. But we also have a lot of research that suggests a number of techniques and also medications that might be helpful with high disinhibition. So behavioral monitoring, goal setting, and planning can be particularly helpful with an individual who is presenting with these traits. Getting someone to stop and teaching them awareness so that they can be mindful in the moment. Mindfulness training also may be helpful in allowing an individual, again, to sort of zone in on exactly, let's focus on one task at hand. In general, we're not so great at multitasking. So maybe if we're focusing on one task at hand, this is going to help the individual to be able to focus on that one thing, to remember their homework, or to really engage in some activity. Again, most of us are very familiar with the domain of internalizing. In fact, many problems with mood, emotion discontrol, and anxiety can be related back to internalizing, and a number of psychopathology constructs, as described by DSM, are related to this internalizing spectrum. And so some treatment challenges here is we are going to see individuals who are experiencing distress. They are going to be experiencing a number of psychological symptoms. And so sometimes that can be a little bit challenging. It may be overwhelming in terms of determining treatment targets. Again, though, because internalizing has been related to so many DSM disorders, what that means is we have a lot of high-top adjacent constructs that we can look to for what is effective in terms of treatment. So cognitive processing and cognitive restructuring, the use of SSRIs and tricyclic antidepressants have been very effective in treating internalizing disorders. More recently, the Unified Protocol, which I'm going to talk a little bit more about in a bit, has been developed specifically to look at this broad transdiagnostic factor. And we have some evidence that it is effective in reducing symptoms. So the spectra of thought disorder really encompasses these psychotic symptoms, oddity, eccentricity, perhaps some of the disorganized behavior and cognitive perceptual aberrations. There are a number of treatment challenges, building rapport and developing that trust within the relationship may also be a challenge with individuals who are high in the thought disorder spectrum. We don't have quite as much work outside of psychopharmacology on thought disorder, but there's some work from the early 2000s that some social skills training and normalizing rationale may be helpful. More recently, mindfulness and acceptance and commitment therapy techniques like cognitive diffusion show promise in individuals, perhaps individuals who maybe don't have schizophrenia, but they have some of these thought disorder symptoms that actually Dr. Cicero probably has a lot more information about this than I do, but there is some promising treatment even outside of the use of psychotropic medication that may be useful in individuals with elevated thought disorder. And then finally, somatoform disorder. These are highly speculative. We have a little bit less research on this spectrum in general, but this relates to concerns with health. DSM disorders like somatic symptom disorder or illness anxiety disorder would fall under the somatoform spectrum. And our recommendations here are going to go really off of those diagnostic constructs. And so the information that we have about treating somatoform disorders include things like cognitive restructuring for illness anxiety disorder and somatic symptom disorder, using cognitive restructuring to deal with the anxiety, and teaching some exposure, like some interoceptive exposure, may also be useful alongside psychotropic medications. So these are all just, kind of my quick run through of how can these high top spectra help inform our clinical practice. What if we have these scores, if we decide, okay, our clinic is going to use the high top DAT, how do we use that with the person sitting in front of us to select treatments and to think about our conceptualization and how that helps us with treatment planning. So sort of bouncing off of Dr. Hopwood's example, we can think about Dexter. We talked about how internalizing spectra, detachment, and thought disorder were all elevated, and antagonistic externalizing wasn't quite elevated, but we did see that anger really seemed to be driving a higher score in this individual, and at sort of a lower level. Chris described this person as having some anger problems, some identity problems, thought disorder, over-controlled impulses related to that anger. So then what would we do if Dexter presented in front of us? Well, first I want to start by saying, again, a disclaimer, the impact on gender identity and sexual orientation and treatment selection is something that Dr. Rodriguez-Sejas is going to be talking about directly following our presentation. And so it's something really important that given the questioning and the difficulties with identity that Dexter was presenting with, this is something that absolutely needs to be taken as a cultural consideration and thought about when making treatment decisions. But I would think that starting with a unified protocol might be something that would be particularly helpful for Dexter, specifically because it is a transdiagnostic treatment, and the fact that it can be used in a modular fashion. So what that means is that we could go in the order that best suits and determine what makes the most sense for Dexter. And one of the reasons that I really like that is because we talked about therapeutic alliance is something that is going to be particularly challenging with a client like Dexter, because the disengagement, the thought disorder, and antagonistic externalizing, all of those scores in general could suggest difficulties forming a treatment alliance, difficulty trusting a treatment provider, difficulty presenting in and being engaged in treatment. And so the unified protocol starts with a module on motivation enhancement. And so that motivation enhancement can allow us to build empathy, sort of roll with the resistance, like not get in this back and forth tug of war with a client in order to really get him engaged in treatment. And then once we feel like, okay, he is getting engaged in treatment, we have built a good alliance, then we can start introducing some skills. And so due to the distress that he's experiencing, that really high internalizing spectra, the overall, his P-score being elevated, we can dive into internalizing and think about psychoeducation and tracking emotional experience. We can next perhaps do some cognitive appraisal and do some reappraisal with some cognitive restructuring. We can think about emotion avoidance. I really like the way that Chris was talking about this over control of impulses. We can think about how emotion avoidance contributes to that and those emotion-driven behaviors. And once we get through that piece in treatment, we can sort of see how's he doing and then determine what's going to be the most useful next step or next technique. So I think that this talk had more disclaimers than I've ever given in my career, more caveats, and more disclaimers, more, wait a minute, you know, this is all speculation. And that's with good reason. A lot of that is because these are taking adjacent constructs and thinking about how do these apply to high top. So there really is a strong need for future research. And I just want to briefly talk about, you know, this is sort of what needs to be done next. So developing a comprehensive taxonomy on what are the psychotherapeutic techniques that we have that are evidence-based, and being very inclusive in what we are using with our clients. And then we can start generating some hypotheses to determine how do these techniques map empirically onto the high top spectra. So we have a good idea of theoretically what it might look like or how these relate to adjacent constructs, but we need to actually see how do these techniques map onto high top spectra. Then we can begin conducting naturalistic research studies in which both the spectra and the therapeutic techniques are measured in therapy, which could then lead to randomized controlled trials actually studying the use of the high top spectra with these therapeutic techniques. And overall, some of the most important work that really needs to be done is working with clinicians to determine the utility, the efficacy, and the feasibility of using the high top spectra in clinical practice. So thank you for your time. And I see we have some questions that we can start to address.
Nice job, Stephanie. I've been trying to type in the questions, David. I imagine that's what I'm supposed to do, but if not, now's a good time to slap my hand.
No, either way is fine. I think I believe we have one that hasn't been answered yet, which sounds like maybe Chris has already started typing an answer. But the question, I'll just read it for everyone. If a clinician is using high top to guide initial conceptualization, how might the clinician use the high top model measures to engage in regular symptom monitoring with the client to assess whether the treatment is having the intended effect? And they mentioned that traditionally they've used the PHQ-9, the GAD-7, et cetera, to track treatment progress biweekly because they only take a couple of minutes. And how might we do this with high top?
I answered a similar kind of question a little earlier. To me, one of the great advantages of high top is that it's not so much a new model as an evidence-based reorganization of existing knowledge about individual differences in psychopathology. And so most valid measures of psychopathology could be fairly easily placed within the high top system. And so if you're comfortable with and familiar with and trained in a particular measure, and you think that that measure both captures the patient's problems well, and also can be easily placed within high top, there's no reason you couldn't use a measure that's not developed from within the high top system. On the other hand, I also know that the high top group have been very active in developing assessment measures that map even more directly onto the system. So to me, I think you can kind of have your cake and eat it too. If you really like using a measure that you're trained and familiar with, there's no reason you couldn't use it. And if it's a valid measure of psychopathology, I'm sure it maps into the high top fairly well. Stephanie, do you have anything to add to that?
No, I think you hit the nail on the head. I completely agree. I think Catherine Jonas would be a great person to help answer this as well. I think getting some assessment of functioning as well, like HUDAS, so not just using symptoms, but also looking at the functioning as well is going to be important as you track across treatment. But I think PHQ-9 and G87 map on really nicely with some of the spectra. So that was a lot of words for me to say what Chris said.
Then Catherine Jonas presented yesterday about the HiTop DAT, the HiTop Digital Assessment Tracker. It's a little bit longer than it sounds like maybe the person who asked this question is looking for, because it takes, I think, about 30 minutes or so to do the follow-up one. It's not as kind of comprehensive as the initial one, but it does take significantly longer than the PHQ-9 and G87 would.
Stephanie, Peter Jacobson's asking about drugs. How can we think about integrated treatment, meaning psychotherapy, psychopharmacological integrated treatment from a HiTop perspective? I think you had a few things in your slides and in your paper about drug classes.
Yeah, so, another disclaimer, I thought I was done with them all. Obviously, for me, this is not something in my area of practice, but there is some good research out there, particularly the use of neuroleptics and thought disorder, SSRIs with internalizing, that have decades of research behind them. And so then using the research that we have with diagnostic, just DSM diagnoses, can be helpful. So we know that some individuals with major depressive disorder improve with CBT alone, some with medication, and some with a combination. I think that this sort of goes back to Chris's point earlier that this is not new stuff. Like, what do we know about major depressive disorder that can be useful when we have a client sitting in front of us who has high internalizing with depressive symptoms? Well, we know that those treatments for depression potentially are going to be useful.
Somebody with the charming name of anonymous attendee has asked, if the HiTop's assessing traits, why do we think traits should change in treatment? This is a very short question. Stephanie and I could probably talk for the next 7 days about the answer to that question.
Yeah, it's my favorite.
Maybe I'll just, do you want to go first, Stephanie, or should I? Yeah, I have a variety of reactions. One is that there's pretty good evidence that personality traits change, particularly in response to intervention. There was a meta-analysis in Psych Bull in 2017 about how personality traits in response to interventions, the effect sizes tend to be in the order of like 0.6 within the first 6 weeks or so. So I don't think traits should scare us necessarily. That's one thing. A second thing is that the HiTop doesn't really measure traits. So there's a difference between saying that the structure of individual differences in psychopathology symptoms and the structure of individual differences in personality are very similar to the degree that they're nearly parallel, almost exactly the same with a few exceptions. That doesn't necessarily mean that all symptoms and all traits are going to have the same level of stability. That's kind of a different question. So one way to think about this is maybe it's not super surprising that if you factor analyze questions about what people are like, you get a sort of similar model, whether you're asking what they're like in general, what kinds of problems they have. People have sort of different theoretical interpretations of what that might mean. My guess is that Stephanie and I would share the view, correct me if I'm wrong, Stephanie, that that's probably because personality is kind of the basis for the kinds of problems people are most likely to have. So if you're really detached and really neurotic, then you're at risk for depression because that's the kind of personality risk factor for a depressive person. So that's my best guess about why that happens. But I think there's a kind of deeper and really interesting question that's being raised here, and one which I actually wanted to ask Stephanie about anyway. So here's my chance. So processes are within person and idiographic, often idiographic, sometimes not idiographic, but sometimes they are. Meaning, as a clinician, one thing I want to know is like, what kinds of problems is this person likely to have? And HiTop, I would argue, is the best available thing on the market to tell you what kinds of problems a person is likely to have on average, and how one person's likely to have different kinds of problems than another. As a clinician, I also want to know things like, yeah, but when are they going to have those problems? What are the contexts? What are the situations in which they might manifest, et cetera? And that's a within-person question, not a between-person question. Within-person questions can't be answered in cross-sectional data by definition. So there is a piece, in my view, as a clinician that's missing, that there is some work to do still in making a treatment plan once you get past HiTop, which clinicians are familiar with, which is the processing part of the model. So, and I think this is not exactly what anonymous attendee is getting at, but it's where my mind goes, which is how far have we gone in solving the riddle of psychopathology and treatment with a really good cross-sectional model? Or how do we deal with the fact that many of the interesting questions for clinicians have to do with the whens and the wheres and the hows and not just the whats?
I like that you're starting with like the easy softballs on a Saturday morning.
It's Saturday afternoon for me. I've been thinking about it all day.
So you've had like 12 hours to think about it.
Exactly.
Yeah, so I think that in general, like we still have really far to go. I think that as clinical health psychologists, as health service providers, there's so much that we aren't yet able to do. And I think no area is a better example of this than our suicide research. That when we look at, we've been doing research on individuals who attempt to die by suicide for 50 years, and we have not gotten really good answers on what is going to predict those variables. And so I think that, you know, as a psychologist, as a researcher, that's disheartening. And I don't want to leave that for folks today, but I think that does mean that we need to get better at asking questions. And part of this, I know, is something that Chris and I have talked about on a number of occasions. We need clinicians as stakeholders. We need folks who are, this is why we're doing this, right? This is why we're taking HiTOP 2 clinicians to answer these kinds of questions. Like, what are the things that we need to know? Like, because if we see that internalizing is correlated to DSM disorder, like, what does that mean in practice? Like, what do we actually do with the person who's sitting in front of us, who's experiencing distress? So mapping these onto techniques and then determining outcome assessments, I think are going to be really important. I do agree with you that we don't need to be afraid of traits. That I think you and I may have slightly different definitions or variations on this, in that I think that the overarching trait is relatively stable. It's the manifestation of that trait that we see changing, and that's really hard to differentiate in assessment. So we may have an individual who has borderline personality disorder as a DSM construct, and we teach them skills, and their overarching like emotion dysregulation, they may still be predisposed to emotion dysregulation, but they're much better at adapting to that and regulating their emotions. So for me, the underlying trait may not be changing quite so much, but we're just not great at measuring that. But I feel like I have rambled off of my soapbox for a minute, so.
You really set it up. I was hoping we're going to have a real fight there, but I think I agree with everything you just said, unfortunately. So, yeah, no, it's real tough to tell the stable disposition from the way it manifests in life. And I think the way we generally think about it heuristically is like, you're not going to take a super neurotic person and make them not neurotic anymore, but you can help a neurotic person live their life in a way that's adaptive and maybe not always pleasant internally, but at least manageable and meaningful. There's actually kind of a related question that I already answered from, I think it was Brandon, about you'd mentioned, Stephanie, that the low parts of some of the HiTOP dimensions aren't there. This is kind of a tension in the world that we live in, because Stephanie and I were both trained in part in normal personality, and in a normal personality, Stephanie, maybe you've heard of this thing called the 5-factor model. I don't know if you're familiar with it, but that has distributions that look like a bell, like we all saw in statistics class, where so an agreeable trait, for example, will have antagonism on one end, which is what the HiTOP focuses on, but then the variation in the other end, that is high agreeableness, is also going to be interesting on a normal range personality measure. So Brandon, I think, and I'm sorry if I'm getting your name wrong, asked, so how are you going to get those strengths that you're talking about that the HiTOP doesn't do a great job of focusing on? And I said, well, one thing you could do if you have enough time and energy is you could give a normal range personality measure. Of course, those things can be hundreds of items, and we don't always have time for that. But what that can buy you is an even more holistic perspective on the person, particularly if it's faceted, then you get a pretty specific idea in a way that maps pretty closely onto the HiTOP system with, again, some fuzziness here and there of the low ends of those traits with a greater level of fidelity and reliability. So I'd be really surprised if Stephanie hates this idea, but probably you have something to add. Do
No,
you
I
give
love
normal
this
range
idea.
measures? I guess that's a concrete question. Do you give normal range personality measures in clinical assessment routinely?
Oh yeah, I do for sure. And I find it's so helpful too in giving feedback. I mean, I think Chris and I both are big fans of therapeutic assessment and therapeutic feedback. That, you know, I would say that I've probably had maybe 3 or 4 clients in the last 5 years that giving them the assessment itself was therapy, and they were like, oh, okay, so that's all. No, that's good. Now I know that how I relate to the world. They come in, why do I feel anxious all the time? Well, let's look at your score in neuroticism, your predisposition toward anxiousness, and that's, you want to know why. That's it. Good. So I think that normal range personality tests absolutely have a place in clinical treatment, not only for the kinds of problems people are having, but also their strengths. And this can give you a lot of information about how they relate to the world and how they're going to relate in the therapy room. And I absolutely think that can help. You know, that I know that has been a real sort of tension in HiTOP is, what do we do with these other sides of traits? So I think disinhibition is a really good one. Where's compulsivity? What is low disinhibition? So we have a way of measuring that one, but we don't really have a way of measuring the flip side of antagonistic externalizing. We don't have what normal range personality would call agreeableness, or what we might call maladaptive agreeableness, which might be related to a host of problems. And so that has been a tension. If Tom Whittaker were here this morning, he could just take over and spend the next 20 minutes talking about how we need a little bit more of that bipolarity, but I know that that's a little bit hard to assess, and we don't have that so much in the HiTOP model.
Yeah, there's like historical reasons why that's not in there, which is that on average, it's worse to have low agreeableness than high agreeableness. But Tony just made the point in the chat, sometimes people's problem has to do with high agreeableness. And the fact that on average this is a nomothetic issue. So like the fact that on average, the base rates are such that it's worse to have one side of the trait than the other leads to models, because we're focusing on how different variables covary with one another, that end of the trait is going to covary with dysfunction. And it leads to the idea that, well, therefore, that's the end of the trait we need to focus on. But when we go to the individual person, that doesn't mean that that's the person, that's the part of the trait that's the biggest problem. And so Tom and I can find things to disagree about, but this is not one of them. So I guess, Stephanie, you'd agree that the normal range measures are one way to deal with this, but you'd go even further and say, well, there's also there's also measures developed by your crew to capture the maladaptive ends of the other side of those dimensions.
Yeah, I mean, I think that so for those who don't know, Chris was joking earlier, my background is in 5-factor model general personality research. So it is what we might call normal or adaptive personality traits. And the measures that we have of those sometimes are limited, particularly in the assessment of problematic traits at those high ends. So for example, the NEO-PIR does a really great job assessing agreeableness and antagonism within these adaptive ranges. And then it does a pretty good job of maladaptive low agreeableness or maladaptive antagonism. But if you look at the questions, they may ask things like, you know, I get along with people. So if you tap out on the very high end of high agreeableness, it just means you're an agreeable person. What it doesn't mean is that you're a doormat, or that you're overly passive, or that you run into problems due to maladaptive high agreeableness. The NEO-PIR does not get at that problematic traits. And so Tom's lab really has developed a number of measures that can get at those maladaptive FFM traits that you might not see with like a NEO.
David's got a question. I'm just reading through it now. I'll just read it for the group. I wonder if HiTOP makes it easier to think and conduct research and treatment about the interaction of various spectra, subspectra, subfactors, et cetera, and how they manifest in a particular person. That is, if the traditional diagnostic models beginning with Kraepelin allowed us to divide people into the primary colors of psychosis, neurosis, PD, et cetera, and the secondary colors of paranoid, mania, OCD, et cetera. David thinks it's a weak metaphor. You guys can decide for yourself. HiTOP helps us think about and examine how these primary colors blend and make secondary colors, which in turn blend to become tertiary colors and so on, as well as the intensity of the colors. Yeah, I mean, I think that's right. That's I like the circular metaphor personally. This is something that Stephanie and I could probably find a way to disagree about. But that's the advantage of dimensions, right? Is that when you turn stuff that's dimensional in nature into categories, it becomes easy to categorize and communicate. And that's why we think of colors in terms of red and blue and green, which is a mix, I think, of two other things or something like that. But still, we think of it as a category, as a green, rather than as a blue plus yellow. That's a useful thing to be able to do for certain applications, but ultimately it's not true. And it's those gradations that we're kind of after as scientists. And I think the question is, as you say, does capturing those gradations in a more evidence-based manner, the way HiTOP does, help us capture more subtle connections to treatment in the ways that Stephanie was just describing? And that's kind of the big question moving forward that I think empirically is not answered, but that's kind of the bet that those of us that are passionate about HiTOP are making, is that, yeah, by capturing those dimensions, at least we have the opportunity to get closer to treatment, because after all, treatment hasn't really evolved in about 70 years. And so maybe this is the hook that we need. Antonio wants to know about validity scales and HiTOP measures. Oh, I'm sorry, Stephanie, did you have anything to add to David's good question?
No, I mean, I think it just caused me to think in general that I think most clinicians, the way that they conceptualize does use information on a regular basis. We've already talked about this, like internalizing major depressive disorder, like whatever it is that we're calling it, we use that. But ultimately, I really like Jacqueline Person's case conceptualization. When you have someone in the room, you're looking at their problems. So in general, it's helpful to know if they're high in internalizing spectra, but where we want to really focus is, what are the problems that we're having? How can these be grouped together? And what treatment techniques do we have that are connected to those? And so I get really excited thinking about the future of HiTOP and the future of clinical translation, because we can not only perhaps map techniques onto HiTOP spectra, but looking into specifically the problems that are associated with those spectra. I think having sort of an empirical log of those would be really cool.
Antonio is asking about validity scales on HiTOP measures. You guys want to take that?
I think I answered. That's the plan. I know that's something that's being worked on. As I'm not sure what phase we're on in the measures group of HiTOP right now. I think we're on phase 2B or phase 3 to get HiTOP 1.0 out by spring of 2023. And the plan is to include validity measures. We'll include something like a 2-good scale. So trying to get at that positive impression management, like what's called in the PAI, or the faking good in the MMPI, as well as some inconsistency and infrequency scale type things.
Jill
no copyright implied.
Oh, sorry. Jill wants to know where we can find norms, I think. Are there plans to collect and distribute information about norms for interpreting HiTOP scales?
I don't know if David has a better answer to this than I do, but I know Catherine Jonas, who spoke yesterday about the HiTOP DAT, is trying to get the HiTOP out to as many clinics as possible. So again, if you're interested in bringing the HiTOP DAT to your practice, just to check it out, there's no commitment, you don't have to use it, but just to check it out. I think the goal here would be to use those clinics to help develop normative data.
And Stephanie, how much is the HiTOP measure going to cost when it comes out in 2023?
I believe it's estimated to be about $0.00.
$0.00. Okay.
And there'll be both paper and pencil version, or a Qualtrics or REDCap version.
And also 0 francs, I hope.
Oh, yes. Yeah. Sorry,
Okay.
I am very, very American biased today.
Xenophobic. You mentioned one of your disclaimers had to do with your CBT bias. And I was just going to mention that Dexter was based on an actual person that I treated from a psychodynamic point of view. And I thought, well, if there's still time left over, I could talk a little bit about that. But I want to make sure that we answer questions first. But right now, there don't seem to be any questions.
I would love
you
that.
talking about that at all?
Yeah, otherwise I was gonna contact you and be like, talk to me about Dexter, because I based all of my information off of the slides that I saw in advance.
I'm glad that that was useful. Probably I should have given you more information about Dexter ahead of time. Excuse me. Oh, real quick, are there PhD problems to get further training in the development of application High Top? Has North Texas got a PhD program, David?
Yes, we do. So I think most of the consortium members of High Top are doing, High Top related work in their own labs as well. And I think most, or any of us would be good people to work with for that kind of training.
Yeah, I think Stony Brook and UNT would be the real hotbeds for High Top researchers, right?
Peter likes us, I think. That's how I'm interpreting this. Likes how the different stuff combine and interact, and the whole person piece. Excited to see how treatment packages would move these complex systems. Okay, I'll take that as a comment. So the first question we had with Dexter was whether psychosis is the most likely problem because of the trajectory and the age and the symptom presentation. We thought, well, that's a concern. So our first focus was in ruling that out, and we were satisfied that that probably wasn't what was going on, that the cognitive disorganization was secondary. Given his kind of suspicious nature and with respect to authority, his high intelligence, and his introspective nature, I made a kind of decision to not do something directive along the lines of CBT. I use cognitive behavioral therapy and a variety of different techniques in my practice. I don't know why. I mean, there's no evidence for treatment matching, but it seemed to me, based on my best guess and the data that I had at hand, that something more reflective would be a more useful approach for Dexter. And that's why I went with a more relational approach. I guess my formulation was, this is a person who had a lot to figure out about himself. And because he didn't have a particularly supportive environment growing up where he was given space to think about some of the things that he was dealing with, he hadn't been given an appropriate opportunity to figure those things out, and that psychotherapy could provide that space. He sort of took to that approach, and the alliance developed pretty quickly. And as I recall, his sort of core, and if anything, the sort of defensive pattern that worried me the most was not so much suspicion, but actually dependency, because I think he got quite attached to me. In a way that in some ways later interfered with his efforts to try to reconnect with the social system, and in particular his family, because he was quite ambivalent. He wanted to be connected to his family, but part of him was pretty angry and resentful and thought he would never be fully accepted, and therefore he didn't want to have any part of them. So that was a major theme, as I recall, of the second half of the treatment. And he did end up making some kind of like limited, with very boundaried effort to reconnect with his family towards the end. In the beginning, there was just a lot of preoccupation and concern around sexual orientation, gender identity, and he had questions about what was really him and what was a reaction to a sort of a very constrained worldview. So neither one of those things were acceptable in his origin culture. And he did end up identifying as gay and male, but that was the main thing that he was sort of working through in the course of the first half of the therapy, as I recall. And yeah, what was psychodynamic about that? Well, mostly my concerns were trying to manage the alliance and this sort of at first that would be kind of suspicious, paranoid, insecure attachment, which, as I said, I think ended up being, if anything, there was more of a risk of enmeshed attachment. So sort of managing that alliance and then using the relationship as a sort of lab to talk about other relationships and how that's gone. And then to help him reflect on who he really is, independent of all these. So he had like, who am I? And on top of that was, who do other people want to be? And then on top of that was like, how am I reacting to who other people want me to be or not want me to be? And am I only trying to be gay to piss off my dad, was the kind of things that he would say, right? So he kind of he was sort of real confused in between all these spaces. And that's mostly what we ended up focusing our time and attention on. Craig's here. So anyway, I think the more meta point that I would like to make is that it's always seemed to me that there's there's a really natural correspondence between CBT and high top in the way that Stephanie articulated, and I tried to kind of articulate with the therapy hierarchy idea. But there's also a really pretty close correspondence between psychodynamic diagnosis and high top, in that usually a psychodynamic diagnosis will start with the idea of personality organization or overall ego functioning or whatever you'd like to call it. There's all kinds of jargon in that approach, of course. But that's empirically more or less like the P factor. I think nobody really knows what the P factor is in terms of substance. Like, what are we really talking about? It's just like it's like, what is IQ? It's whatever IQ test measure. So psychodynamic theory has more specific and articulated and Baroque in some cases ideas about what that is. But the idea that we would focus on a general dimension of functioning, I think, has a long history in that approach. And then all the specific spectra, et cetera, have to do with, well, what patterns of defense and dynamics could we expect to manifest in treatment? And then, of course, the big difference is that in CBT, you'd sort of say, well, if this is the problem, you should use a more fear-based, exposure-based kind of a thing. And if this is the problem, you'd use a more skill-based kind of thing, the way that Stephanie was sort of laying out in her lovely way. Whereas I think in a dynamic approach, the question would be, can we help the person see that picture the same way we see that picture? So can we help the person reflect on that picture? And so in that way, the image itself, the high top picture, becomes a useful metaphor for what the therapy is trying to do, which is, can we see ourselves accurately? So I see there's a really kind of lovely correspondence between the dynamic approach and high top, although I'm not sure we've made a lot of inroads in the dynamic community in terms of convincing them about the virtues of the high top system. So do you want to say anything about that? And then Caitlin has a question.
Well, so I was going to say, thank you for sharing that. I really like hearing it. And I like seeing those connections that I know are there, but personally haven't used. And so I'd love to talk with you more about that. And then I was going to point out that Caitlin had a question. And I think this also I'll say, connects back with a question that someone brought up yesterday, which was, okay, so the high top does a good job measuring detachment, but we also know that there are lots of attachment problems, and where is that seen? And so I think that sort of comes back to some of our earlier points. But as you were talking about that sort of like enmeshed attachment, sort of seeing like, we might not have been able to predict that based on the measures that we have from high top perhaps. But yeah, so Caitlin's question is that they're curious if you did any values-based work with Dexter.
I want to be sure I understand what that means before I answer.
I would guess as a sort of acts-based, some behavioral activation.
No, I'm not trained in ACT, and I've not, I mean, in some ways I see ACT as a kind of post-psychodynamic treatment with the sort of trappings of behavior therapy, the sort of language and trappings of behavior therapy. So probably if you had a video recording of me and you loved ACT and you watched what I was doing, you'd probably say, oh, you're doing this thing from ACT, but I'm not trained in it. And so not explicitly, I guess, would be my answer. By the way, I think Jill made a plug for IPT as another treatment approach that people like. I mean, I guess my general idea is like, I'm not a super big fan of acronyms when it comes to treatment approaches. And so I guess what I would say is if a treatment is intended to work and does work, and there's evidence that it does, probably you could use high top to inform what kind of people it would be most useful for and how that would be best approached from a high top perspective. My guess is that there's a way to interface those things if it's a legitimate treatment. Sorry for the snarky comment about acronyms. That wasn't nice.
I know that we're out of time. I think that connects well to David's point, though, that I don't think we've made a lot of great inroads yet in psychiatry. I know that is definitely an area that Roman and Camila are interested in bringing this more to psychiatric providers and psychiatric researchers. That's not somewhere that I think we're quite there yet. But David, I'm going to turn it over to you.
Yeah, and there's a recent paper that I'll share in the chat that was meant to address psychiatric providers more directly. But we are about out of time, so thank you, Chris and Stephanie. Really enjoyed the presentations. And why don't we take about a 10-minute break, and then we'll come back, and Dr. Rodriguez-Sayas will talk about using the HiTOP with diverse populations.